Hello everybody, my name is Dr. Richard Teams. I'm an anesthesiologist. I've been practicing regional anesthesia and acute pain management for over 15 years. And for these videos, we are going to be talking all things regional anesthesia and nerve blocks. Welcome to the Block Show. In this segment, we'll be discussing hip block techniques. Included in this segment will be fascia iliaca and femoral nerve blocks, as well as Peng blocks and lateral femoral cutaneous nerve block. We'll be discussing anatomy, neuroanatomy, as well as medications and dosing and indications for these nerve blocks. For hip blocks, it's very important to understand what type of surgery or hip fracture that we're doing, because depending on what is happening in the hip depends on what type of nerve block we should be doing. For example, in this image, we see three different types of hip fractures. We have a femoral neck fracture, we have an intratrochanteric fracture, and we also have a subtrochanteric fracture. The nerve blocks that we can use for this are femoral nerve block, lateral femoral cutaneous nerve block, Peng block, and fascia iliaca block. Which one should we use? The ideal block for a subtrochanteric hip fracture would be a fascia iliaca block. The reason for this is it gets the femoral nerve and all of its branches. For more proximal hip fractures, such as intratrochanteric or femoral neck fractures, a Peng block might be ideal for this. The reason for that is a Peng block blocks or numbs the articular branches of the femoral and obturator nerve. These articular branches terminate on the greater trochanter. So if you do a Peng block for a subtrochanteric hip fracture, you will miss the pain associated with that fracture. And this I've seen multiple times in clinical practice. Peng blocks are great for hip fractures that are femoral neck or intratrochanteric, or hip arthroplasties or a hip scope. Again, for subtrochanteric fractures, ideally I would use a fascia iliaca block. The anatomy for a fascia iliaca or Peng block or femoral nerve block are all very similar. Home base for all of these blocks would be the femoral nerve block. What you want to look for is the femoral artery, as you can see here in this image, and just lateral to that you will see the femoral nerve. Underneath that, the muscle is the iliacus muscle. If we scan our probe more laterally, we'll see the sartorius muscle. For fascia iliaca blocks, we want to start at home base at the femoral nerve block, scan our probe laterally, be sure that you're underneath the inguinal ligament. Generally, I will use the ASIS as a landmark. I want to be below the ASIS when I'm scanning for a fascia iliaca because I need to see the sartorius. The sartorius muscle attaches to the ASIS, so if I'm too cephalad to that, I won't see this muscle. Once I see the iliacus muscle and the sartorius muscle, I'll turn my probe almost 90 degrees, where it's now pointing towards the umbilicus. From this point, I can see the sartorius muscle, and I can move cephalad and I can see another muscle, which is the internal oblique muscle, which you can see here. The muscle in between the two, which looks pyramidal, is the iliacus muscle. The best technique for a fascia iliaca block would be to go trans-sartorius. I like placing my needle through the sartorius, popping underneath and through the fascia iliaca. After you pop through the fascia iliaca, you want to start your local infiltration there. Fascia iliaca can be a volume block. You can use anywhere from 30 to 50 cc's of local anesthetic. By doing this technique, also known as the bow tie technique, where you can see the bows are the two muscles, either the sartorius or the internal oblique, and the tie in the middle is that fascia combination, which is actually the inguinal ligament. Local anesthetic is spread underneath the fascia, but on top of the muscle, in this case, the iliacus muscle. If you do this technique, you're pushing the local anesthetic cephalad or up towards the umbilicus. This local anesthetic will dive over the iliacus muscle, cephalad, and it bathes inside the pelvic fossa. This is where all these nerves originate from, such as the lateral femoral cutaneous nerve, the femoral nerve, and also the obturator nerve. And this is how you're able to get all three of these nerves, is by pushing this local anesthetic cephalad, getting this local anesthetic up into the pelvic fossa. One of the downsides of a fascia iliaca block is that it will cause quad weakness. The reason it causes quad weakness is simply because we're blocking the femoral nerve and all of its motor nerve branches as it arborizes as it goes underneath the inguinal ligament. This has been one of the downsides to using a fascia iliaca block, say for hip arthroplasties, where say our surgeon wants us to start ambulating our patient right after. Enter in the newer block, such as the PENG block, also known as the pericapsular end nerve group. This block is beneficial because we're only getting the articular branches of the femoral and obturator nerve. These articular branches are mainly sensory. They don't have motor components to them. So doing a PENG block for a hip arthroplasty can be greatly beneficial because now you don't have quad weakness. This has been one of the boons for a PENG block and one of the reasons why we've started to utilize this now in clinical practice. But again, as mentioned before, it is very important to understand what our surgeons are doing in the hip to determine which block is more appropriate, whether it's a fascia iliaca because they're doing a block below the greater trochanter, or if it's above the greater trochanter and towards the hip and the femoral head, then a PENG block will be ideal because you'll get the analgesia of the hip, but without the motor weakness that comes with blocking the femoral nerve. For a PENG block, you can use between 20 and 30 cc's of local anesthetic. I typically will use 25 cc's of local anesthetic for the PENG block. I'll use the other 5 cc's for either a lateral femorocutaneous block or anterior femorocutaneous block, depending on the type of surgery they're doing. If they're doing an anterior hip, I'll put 5 cc's on top of the iliacus muscle in that fascial plane to get the anterior femorocutaneous nerve, or AFCN. If it's a lateral hip, I'll put the 5 cc's for the lateral femorocutaneous nerve to get the incisional pain over the lateral aspect of the hip. To block the lateral femorocutaneous nerve, I'll start at home base with a femoral nerve block, identifying the femoral artery, lateral to that, the femoral nerve, and then the iliacus muscle. Scanning more lateral, I'll find the sartorius. Again, it is important to make sure that you're caudal to the ASIS so that we can properly identify the sartorius. Going further lateral to the lateral aspect of the sartorius, you will see the tensor fasciae lata muscle meet up with the sartorius. Just above the lateral lip of the sartorius is where you'll generally find the lateral femorocutaneous nerve. The lateral femorocutaneous nerve runs over the sartorius muscle caudally and then over the tensor fasciae lata muscle as it moves more caudally on the lateral aspect of the leg. To block the lateral femorocutaneous nerve, 2 to 5 cc's of local anesthetic is all that is needed to block this nerve. Any local anesthetic of your choice can be utilized, whether it's ropivacaine, bupivacaine, or even liposomal bupivacaine to numb this nerve as it goes laterally over the lateral aspect of the hip. This is a great addition to your block armamentarium to get lateral hip pain associated with lateral incisions from, for example, lateral hip arthroplasties. The doses and volumes for fascia iliaca blocks can vary. You can give anywhere from 30 to 50 cc's of local anesthetic, of usually a more dilute local anesthetic. I typically would use ropivacaine, bupivacaine, or even because it's a fascial plane block, you can use liposomal bupivacaine if you wanted this to be a prolonged nerve block. For a PENG block, you want to start your scan at home base with the femoral artery, femoral nerve. At that point, you want to increase the depth of your ultrasound probe until you start seeing the bony structures underneath the iliacus muscle. At that point, you want to manipulate your probe until you see one continuous white line, as shown here. Medially is the IPE, which is the iliopubic eminence. Laterally to the lateral hump, which is the AIIS, or anterior inferior iliac spine. In between those two structures, you'll see the psoas tendon, which is a nice hyperechoic structure there. The ideal location for placing your local anesthetic is going to be to the lateral aspect of the psoas tendon, right in that trough there, also known as the trough of Schwartz. Local anesthetic can be placed there up to 20 to 30 cc's of local anesthetic. Local anesthetic needs to go all the way to the bone and infiltrate it underneath the fascia covering the muscle and the psoas tendon. This can be very challenging. In fact, it can be very challenging and difficult to inject local anesthetic there, and it should be. If it is easy to inject local anesthetic there with a 30 cc syringe, then you're generally doing it incorrectly. What's most likely happening is the local anesthetic is bubbling up into the muscle itself. This can be a problem because local anesthetic can go around the muscle or the fascia iliaca and numb the femoral nerve. This can cause quad weakness. In fact, this is one of the many reasons why there's been many case reports of quad weakness associated with a Peng block. As mentioned earlier, a Peng block shouldn't cause quad weakness because we're only blocking the articular branches of the obturator and femoral nerve. Those nerve branches are only sensory nerve branches and they are not motor nerve branches. But if you put your local anesthetic between the fascia covering the iliacus muscle and the iliacus muscle itself, that local anesthetic can wrap around the iliacus muscle, thereby getting the femoral nerve. The local anesthetic needs to be deposited between the bone and the fascia covering the iliacus muscle. Again, this can be very challenging. One tip I've utilized for a Peng block is utilizing a 10 cc syringe. Injecting at high pressures at a 10 cc syringe is a lot easier than injecting at high pressures with a 30 cc syringe. This has allowed me better ability to infiltrate that local anesthetic on top of the bony structures of the iliopubic eminence, but stay underneath that fascia covering the iliacus muscle. Another technique that can be used for a Peng block is going to the medial side of the psoas tendon. This can be a little bit more challenging because the psoas tendon can be in the way. However, depending on the trajectory of your needle, that needle can go down and touch the IPE as shown here. If you touch the IPE, that local anesthetic can bathe over the bony structures or the brim of the pelvis going under or lateral to the psoas tendon. This is ideal. This is something that needs to be seen while doing this block or this technique of the Peng block. The articular branches of the femoral nerve live underneath and to the lateral aspect of the psoas tendon, in the trough of Schwartz, if you will. The articular branches of the obturator nerve live medial to the psoas tendon, over the iliopubic eminence. You're going to get more bang for your buck putting your local anesthetic on the lateral aspect of the psoas tendon because the articular branches of the femoral nerve live there, and most of the innervation to the hip comes from those articular branches of the femoral nerve. You do get innervation to the hip from the obturator nerve, but a little bit less so. So if you have to make a choice between putting your local anesthetic on the medial aspect of the psoas tendon or the lateral aspect of the psoas tendon, always err on the side of putting your local anesthetic on the lateral aspect of the psoas tendon in the trough of Schwartz and infiltrating that way, thereby getting the articular branches of the femoral nerve. You will get the articular branches of the obturator nerve as that local anesthetic spreads up over the bony structure towards the iliopubic eminence. Again, for Peng blocks, I'll use 20 to 30 cc's of local anesthetics. I like using 25 cc's and reserving the other 5 cc's for one of these other blocks, such as the LFCN nerve or AFCN nerve blocks. But 25 cc's of local anesthetic is going to be enough to cover that whole area over the pelvic brim. This nerve block can last a long period of time, depending on how well you do it. Even with ropivacaine, it can last up to a day and a half. With liposomal bupivacaine, it's lasted up to 3, sometimes 4 days, because that local anesthetic hangs out there. It stays on the pelvic brim and in between the iliacus muscle and just sits there bathing those articular branches that are very, very small, easy to block, and causes exceptional analgesia to the hip. One thing that you can miss for some hip fractures or hip surgeries can be the posterior part of it, but most of the time this is not as painful as this anterior part, which is innervated by those articular branches of the femoral nerve and the obturator nerve, which we're getting when we do these Peng blocks and fascia iliaca blocks. One more thing I want to say about lateral femorocutaneous nerve blocks is it can be used for any type of incision that's on the lateral aspect of the leg. This could be anywhere from knee arthroplasties to ACL surgeries. Oftentimes there's a small incision on the lateral aspect of the leg that can be lateral femorocutaneous mediated. You can do this block as a rescue block for that type of pain that's on the lateral part of the knee or leg. The other technique that's associated with doing a fascia iliaca block is doing what is considered a lateral femoral block. This is where you start at home base, move your probe laterally until you see the sartorius, putting your local anesthetic underneath the sartorius muscle in that location. Will that work? Yes, it will work. By doing it this way, however, you're pushing your local anesthetic towards the femoral nerve, thereby giving more concentration in local anesthetic that way. If you do the bow tie technique, or rotating your probe to where it's pointing towards the umbilicus, as I'll show you when we do the scanning session, you're pushing that local anesthetic cephalad into the pelvic fossa. By doing that, you're getting some of those articular branches of the femoral nerve that branch high up in the pelvic fossa and dive into the pelvis or the hip. This usually will cause a much better analgesia to the hip than just doing what is considered the lateral approach to the fascia iliaca. One of the things you want to be considerate of when you're doing this block is you want your patient completely supine. I see a lot of the times when patients are tilted up at an angle even 15 degrees, what happens is that will collapse the inguinal crease area and make it a little bit more challenging to do this block. Not only fascia iliaca blocks, but also PENG blocks, which we'll discuss in another video. Once you have your patient in the supine position, we're going to expose the area that we're going to be working on here, and I'm going to use a linear probe. This is a high frequency linear probe for this, and home base for this is going to be starting at the femoral nerve block, which is generally just caudad to the inguinal ligament. On the ultrasound probe here, you're going to notice that the right side is going to be medial, the left side is going to be lateral. I place my probe in here and I go medial, and here you can see our nice femoral artery, and then just to the lateral aspect of this is going to be our femoral nerve. Right above the femoral nerve, this nice hyperechoic fascia is going to be the fascia iliaca. This is the ideal location for putting a femoral nerve block. What I like to do when I do my femoral nerve blocks is I'll take my needle going medial to lateral, just like this, and putting the needle piercing through the fascia iliaca, and between this is the iliacus muscle, and between the iliacus muscle and the femoral nerve, this is where I like to start depositing my local anesthetic. You can certainly come and attack the nerve on top of it this way, but the problem with that is a lot of times when you put your needle above the femoral nerve, it's hard to pierce the fascia iliaca, which is here. It's a very fibrous fascia, and if you put your local anesthetic above the fascia iliaca, the femoral nerve block is not going to work or last as long. And it can also be challenging piercing through the fascia iliaca into the femoral nerve, because you can also damage the femoral nerve. So it's ideal to try to pierce through the fascia iliaca to the lateral aspect of the femoral nerve, come underneath it, and then start your local infiltration, seeing local anesthetic going all the way around the femoral nerve. You can certainly blast this nerve away with 30 cc's of local anesthetic, but you certainly don't need to. 10 cc's of local anesthetic is plenty enough local anesthetic to get an effective femoral nerve block. Moving on to a fascia iliaca. This is our home base for doing a fascia iliaca. You want to start here, find the femoral artery, femoral nerve. As you're in the inguinal crease, you want to move laterally until you start seeing the sartorius muscle. And this is the sartorius muscle here. Again, this is the iliacus muscle, and you can see our nice fascia iliaca plane going right here. Once you see the sartorius muscle, you want to rotate the probe until it's now pointed towards the umbilicus. So now we're crossing the fascia iliaca at a 90-degree angle from what we were originally doing. If we move cephalad towards the umbilicus, you'll start seeing another muscle. This muscle over here to the right side of our screen is the internal oblique muscle. If we go caudad again, you'll see again the sartorius muscle. And this plane right here that I'm outlining with the arrow is our fascia iliaca right here. Now the nerves that we're targeting are going to be the femoral nerve, the obturator nerve, and the lateral femorocutaneous nerve. These nerves live underneath the fascia iliaca, and so the best way to approach this is going to be taking your needle, and we're going from a caudad to cephalad approach. We're aiming the needle towards the umbilicus. By doing this, the needle and the local anesthetic is going to go through the sartorius. I like going transsartorial, piercing through the fascia iliaca, and then start depositing your local anesthetic here. Once you do that, you'll notice the iliacus muscle usually kind of starts dropping, and you can advance your needle cephalad towards the umbilicus, injecting as you go until you see local anesthetic coming up this way underneath the lip of the internal oblique muscle, which is here. One thing that's interesting to note when you're scanning this is the typical bow tie sign. And you can see here on the right side the sartorius muscle, which is one side of the bow, and then on the right side is going to be the internal oblique. It doesn't always look this great because the sartorius muscle will almost always look like the iliacus muscle. In contrast, in the way it appears on your ultrasound machine, it looks very similar. And this plane between the sartorius and the iliacus muscle is nice, bright, hyperechoic. There's no other shadowing. It's a nice, bright, hyperechoic fascia, which is the fascia iliaca. However, when you move cephalad and you look at the internal oblique muscle here, it doesn't look the same way. The internal oblique muscle is not as hyperechoic, or the resolution isn't as good. And the reason for that is because underneath it, there's usually a nice adipose tissue fat pad there, and it changes the look of it on ultrasound. It's a little bit more hypoechoic. I call it schmutzy looking. It looks a little bit more schmutzy, whereas over here, it doesn't. It's very nice and hyperechoic, and it looks like our typical muscles. So it can be really confusing to see this bow tie sign, especially in an older patient, because the internal oblique muscle is not going to look just like your sartorius muscle. Don't let that fool you. This is why I like going transsartorial, because once you pierce through the fascia iliaca, you're in the plane. You can dump all your local anesthetic there. Again, this is going to be a volume block, so you want to use between 30 and up to 50, sometimes even 60 cc's of dilute local anesthetic to get the block that you want to do in order to block the femoral nerve, the obturator nerve, and the lateral femorocutaneous nerve. Another scanning technique that you can use is starting at the ASIS and already having your probe tilted or in line with the umbilicus. If you start at the ASIS here and then you start moving medially, you'll immediately see that bow tie. So here on the left side of the screen, we see our sartorius. On the right side of the screen, we see the internal oblique, which is the nice bow tie sign that we're trying to look for. That's another scanning technique that I've noticed a lot of people like using, rather than doing the medial to lateral, rotating the probe. The other comment I would like to make about this technique for fascia iliaca, the other ways that a fascia iliaca plane block have been noted have been doing a lateral femoral approach. The lateral femoral approach is like this, where you find the femoral nerve, here's the femoral artery, and I just put my local anesthetic way out here laterally, over here. So if I were to use it with a needle, I would just put it way laterally here. The only issue I have with that is you're pushing the local anesthetic medially towards the femoral nerve. That's the nerve we're planning on getting anyway, but the problem is it's not moving the local anesthetic cephalad into the pelvic fossa. By putting your local anesthetic into the pelvic fossa, there are several articular branches of this femoral nerve which branch high up in the pelvis and then spread down over the iliopubic eminence into the hip. By pushing your local anesthetic medially, you may not have enough volume to go cephalad into the pelvic fossa in order to get some of those articular branches. So I've noticed sometimes when those blocks have been performed, I've certainly done it that way, the block hasn't been as great as if you do it the other way, where you're pushing the local anesthetic cephalad into the pelvic fossa, thereby getting some of those articular branches of the femoral nerve, which will help you with your hip pain and hip fractures and everything else you're trying to accomplish while you're doing this fascia iliaca block. Similar to doing our positioning for the fascia iliaca block, you want to make sure that your patient is completely supine. You do not want them to be sitting up in any degree, because you want to open up the inguinal crease so that it's nice and flat. Once we expose our patient here. I'm going to show you how we are going to scan for the ping block. I'm going to show you two different ways to scan for the ping block using two different probes. One is the linear probe, high frequency linear probe. You can use that on most normal sized patients, but for a larger patient, you might need to use a curvy linear probe. I'm going to show you both different techniques. The first one I'm going to show you is with a linear probe with this extended field of view, so you can see a little bit more of the anatomy deeper in the deeper structures. So doing this block, what you want to do is start at home base, and home base is a typical femoral nerve block. And here we go. We have a femoral nerve block right here on the right side. We have our femoral artery. To the lateral side, we have a femoral nerve. Once you get to this point, and I've already kind of done it in this image, is you want to make sure that you are deep enough to where you start seeing a bony structure. Now I see a bony structure here. Typically what you want to do is you want to start in the inguinal crease. Once you see a bony structure, you can start manipulating it a little bit. From here, I see two double white lines. This is actually the femoral head and the acetabulum as the femoral head is going into the acetabulum. If you see this, you're too caudad. If I slide a little bit more cephalad, you'll start seeing this nice white continuous line. And this is what we want to see. This is actually part of the pelvic brim. I'm going to manipulate the probe just a little bit by taking the lateral aspect of the probe and moving it a little medially. By doing that, I can kind of make that nice white line a little better, like this. Here we again have our femoral artery, femoral nerve, deep to this, and this little hump right here is the IPE, or iliopubic eminence. Just to the lateral aspect of the IPE, we see this nice hypercoic structure, which is the psoas tendon. If I go a little bit more lateral, you'll see this nice bump here, which is also a bony structure. This bump is the AIIS, or anterior inferior iliac spine. And then it makes this nice little trough here, which we call the trough of Schwartz. One thing I want to point out on this image is this other hyperechoic banding that you'll see inside the iliacus muscle. This is actually the iliopsoas muscle, because we have part of the psoas muscle in here and then the iliacus, which makes up the iliopsoas. But this hyperechoic banding here can be a little confusing to a lot of people when you're doing this. A lot of people think that this is part of the psoas tendon, or this is a fascia or a bone even. It is not. What this is this is the interiliopsoas fascial cleft. And it will show up like this a lot, kind of like a C-shaped fascia that kind of curves around the psoas tendon, which is right here. It's okay to go through, it's just a fascia layer. But when we do this, we want our needle to come down here and touch the bone just to the lateral aspect of the psoas tendon. So this is going to be the direction that our needle is going to go. If you go in at a 45-degree angle, that's usually a pretty good trajectory in order to go into that that little cleft on the lateral aspect of the psoas tendon. Another way to do this is actually going up above the psoas tendon and hitting the IPE here medially to the psoas tendon. This can be a little bit more challenging because the psoas tendon can be in the way. You certainly don't want to go through or try to touch the psoas tendon because you can cause psoas tendinitis, which is terrible and it's not very fun for the patient. Not only that, it's pretty impossible to get through that psoas tendon. It is very thick. So you want to either go to the lateral side ideally or to the medial side. You don't need to do both. If you can get to the lateral side, you can dump all your local anesthetic there. I generally put 20 to 30 cc's of local anesthetic there. I'll use 25 cc's of local anesthetic here because I'll use the other 5 cc's to either get the anterior femorocutaneous nerve for anterior hip arthroplasties, or 5 cc's for a LFCN nerve block, which I'll show you shortly, for a lateral hip arthroplasty. This is the technique I use for a linear probe. Now I'm going to show you a technique to use with a curvy linear probe. I'll put the probe in the inguinal crease and identifying my femoral artery, femoral nerve. Again, this is home base for this block, and I'll make sure that my probe is deep enough to where I start seeing a bony structure. Here I'm seeing the exact same thing I saw last time when I was using a linear probe, where I see these two curved white lines. This bottom one is going to be the femoral head, the top one is the acetabulum. If you see that again, you're too caudad. You need to move the probe a little cephalad. Now I'm going to do that here. I'm going to move the probe just a little cephalad. That was literally a half a centimeter, maybe a centimeter more cephalad. And now I can see this nice white continuous line, which makes up the iliopubic eminence medially. Here's the trough of Schwartz, and over here laterally, this is going to be our AIIS, or anterior inferior iliac spine. Here you can see right by the IPE, the psoas tendon, and then again a little bit lateral, you can see that fascial cleft that's inside of the iliacus muscle. Again, we don't need to worry about that when we go down to block and we go through it with our needle. So blocking this, I'm going to use my needle. I'm going to go from a cephalad to caudad approach, going in plane and coming in and touching the bone right there, just to the lateral aspect of the psoas tendon. When you do this block correctly, you'll see local anesthetic spreading underneath the psoas tendon and on top of the bony structure. You're going to need to make sure that you're underneath the fascia covering the iliacus muscle. This is very important because if you're above the fascia covering the iliacus muscle, that local anesthetic can spread around the iliacus muscle and get your femoral nerve, thereby causing quad weakness, which is what we're trying to avoid to begin with by doing a PENG block. It should be a very difficult block to inject. I like using a 10 cc syringe while injecting this block because it's a lot easier to inject at higher pressures. This goes against everything that we're normally taught when we talk about regional anesthesia, because we talk about not having high pressures when we're injecting. This is one of the exceptions to the rule. It should be a little bit challenging to inject because this is a very tight space between the bony structures and the fascia and the muscle there. And if you inject there, it will ride over the muscle or over the bony structures here and get the articular branches of the femoral nerve and the articular branches of the obturator nerve. These are those branches that will terminate on the greater trochanter of the femur and thereby get great analgesia to the hip. Fantastic block for hip arthroplasties or proximal femur fractures, such as a femoral neck fracture or intertrochanteric fracture. This is the block of choice for that. It gets great analgesia for that. This is the PENG block. Now we're going to move on to the lateral femorcutaneous nerve block, or LFCN. I'm going to use a linear probe. This is a high frequency linear probe. For this block, it is a very superficial block, and because it's very superficial, you can go 2.5 centimeters. I have it at 3 centimeters here, but it's very superficial. You don't need to go very deep at all, even on a larger patient. So on the screen, the left side is going to be lateral, the right side is going to be medial. We talked about home base in our earlier on and in our other videos. Home base for this is also going to be what we're going to do, which is going to be our femoral nerve block. It's easy to find. Put the probe in the inguinal crease, identify your femoral artery, femoral nerve. The other thing you should identify is going to be the ASIS. We want to make sure that we're caudad to the ASIS because if you're above the ASIS, you're not going to find the lateral femorcutaneous nerve as well. We want to find it by the sartorius muscle, which I'm going to show you here. Once we do that, I want to move my probe laterally until I start seeing the sartorius muscle, which is right here. Again, we used this when we were doing our fascia iliaca block. We can see the nice fascia iliaca plane here. I'm going to keep going a little bit more lateral until I see the lateral edge of my sartorius as it meets up with the tensor fascia lata muscle. So laterally here, this is the tensor fascia lata muscle, and then medially is now the sartorius muscle. right where they meet is right above the lateral lip of the sartorius muscle, you'll usually find the lateral femorocutaneous nerve, and that's it right there. Very superficial, it's only a half a centimeter deep. I'm gonna just move it a little bit more lateral here so that I have a little bit of a runway to put my needle. So my needle is gonna go lateral to medial, right here, and very superficial, right under the skin, right under the subcuticular tissue, which is right here that I'm pointing to here. And you don't need a lot of local anesthetic for this. This is gonna be 2 to 5 cc's of local anesthetic. As I mentioned earlier, when I do hip arthroplasties, I'll generally put 25 cc's for my PENG block, and I'll put the other 5 cc's for this to do the lateral femorocutaneous nerve block. And then it's just right here, right where the sartorius meets the tensor fasciae lata muscle. Right above it is where you'll see that nice lateral femorocutaneous nerve. And again, this is a great block to do to supplement hip arthroplasties, particularly lateral hip arthroplasties that make a nice long lateral incision. Any lateral incision to the leg or even the knee, this is one of the supplemental blocks that you can do. And that is PENG and lateral femorocutaneous nerve blocks. Thanks for watching. And here are some other tips and tricks.